Lovely Tuesday, April 20th morning, and I want to welcome everyone to our uh, virtual pediatric grand rounds this morning. Dr. Stephen Marks will be presenting today on recent changes outlined in the National Heart, Lung, and Blood Institute focused updates to the guidelines of asthma management. Dr. Marks joined the Allergy, Asthma, and Immunology Center of Alaska in September 2019 after serving 27 years as a physician in the U.S. Army. He earned his Doctor of Medicine degree at Michigan State University in 1991. Go Spartans. He completed his pediatrics internship and residency at Tripler Army Medical Center in Honolulu, Hawaii. He then went on to practice general pediatrics for 3 years at the Army Hospital in Heidelberg, Germany. He completed his allergy and immunology fellowship training at Walter Reed Army Medical Center in 1999, then served in various allergy immunology positions over the next 19 years. Special interests include pediatric allergies and asthma, chronic cough, difficult to control asthma, food allergy, eosinophilic esophagitis, anaphylaxis, insect sting allergy, urticaria, angioedema, and atopic dermatitis. Dr. Marks enjoys singing and playing the guitar in his spare time. So we look forward to having a preview of that in the future, Dr. Marks. So before we get started, just some housekeeping items. This session will be recorded for educational purposes, and by participation in this Zoom platform, you are consenting to the recording. This recording will be made available on our Alaska chapter website in the next couple of days. And please enter your questions into the chat box, but please also remember to mute your microphone during the presentation. So with that, Dr. Marks, please take it away.
Well, good morning, everybody, and thank you, Anna, for the nice introduction. When we were trying to set up the slideshow here with Dale, we encountered some technical difficulty, and she's wondering why that was, why we were having so much trouble. And I said, well, the answer is simple. When it comes to technology and myself, I'm like a human walking computer virus. If anything can go wrong, it will. But we finally got it fixed. Yeah, so today I'd like to just talk about the updated guidelines. There are some few interesting caveats, mostly related to the use of inhaled corticosteroids and fast-acting but long-acting bronchodilators. And so with that, let's go ahead and proceed through the slides. So the learning objectives today will be to review the methodology that was used to make the recommendations, list the 6 updated topic areas, describe the new ways that long-term medications can be used, and identify multi-component indoor allergy reduction strategies. This is the reference for the guidelines. You've probably looked at these before. There are many pages, many of which are talking about the methodology before they even get to the meat of the matter. But once you scroll down to the meat of the matter, it's generally pretty useful and worth looking at. So these are not a complete revision of the 2007 guidelines, and therefore they did not title this the EPR 4. They just focused on 6 key areas. And these guidelines are designed to support shared decision-making between patients and their medical team. So it started with a needs assessment in 2015, and that was used to determine what needed to be updated in the guidelines. The 2020 guidelines focus on 6 topic areas only, and that's again why they were not referred to as a brand new EPR. The reason that the biologics are not included is that back in 2015, when they started to focus on this, there was at the time only one biologic available for children, and an understanding that this area was about to expand rapidly, which it has. So they opted not to include biologics in this uh, updated version, and hopefully that will come about in the future. This just really talks about the methodology using the grade technology. This is commonly used as a way of validating recommendations. They created evidence profiles based upon outcomes and then developed a decision table, or what they call an evidence to decision table, for each recommendation. And this is what these tables look like. Strong recommendation versus conditional recommendation, how it applies to patients, how it applies to clinicians, policymakers, and researchers. The 6 topic areas: inhaled corticosteroids, LAMAs, indoor allergen mitigation, immunotherapy, fractional exhaled nitric oxide testing, and bronchial thermoplasty. Those of us in pediatrics, bronchial thermoplasty really doesn't apply. So regarding intermittent use of inhaled corticosteroids, this is a rather big change from previously. If you recall, with previous guidance, even mild persistent asthma, the recommendation was to use at a minimum a daily low dose inhaled corticosteroid. So I want to read the slide first and then talk a little bit. But for children ages 0 to 4 with recurrent wheezing triggered only by respiratory tract infections and no wheezing between infections, the panel conditionally recommends a short course of daily inhaled corticosteroids at the onset of the respiratory tract infections. That short course is defined as 7 to 10 days, with concomitant use of an inhaled short-acting beta agonist as needed for symptom relief. This approach reduces the risk of using oral corticosteroids, which was the previous guidance in this age group for when they would have intermittent wheezing.
Excuse me, Dr. Marks, I don't think the slides are advancing.
So sorry. Reading off the wrong computer. All right, so here's the slide that I read you and the discussion. The EPR3, before this little update, didn't address this situation specifically, but did recommend that for managing a mild exacerbation, use a short-acting beta agonist. For a moderate to severe exacerbation, to add a short course of oral corticosteroids. So the change here is not going to oral corticosteroids for even a moderate exacerbation, but trying an inhaled corticosteroid instead. This slide relates to 12-year-olds and above. With mild persistent asthma, they recommend now either of the following 2 approaches. One, which was similar to previously, a daily low-dose inhaled corticosteroid and short-acting beta agonist for quick relief therapy. The other alternative is intermittent as needed inhaled corticosteroid plus short-acting beta agonist for worsening symptoms. So again, they can stay on their current treatment using a low-dose ICS plus albuterol, if you will, or they can use intermittent inhaled corticosteroids plus albuterol in the setting of an exacerbation. Jumping back to the 4 years and older group with moderate to severe persistent asthma, rather than recommending daily inhaled corticosteroid with intermittent use of short-acting beta agonists, they're now saying that for individuals 4 years or older with moderate to severe persistent asthma, the preferred treatment is a single inhaler that contains an inhaled corticosteroid plus formoterol. So most of you would know these inhalers as Symbicort or Dulera. The studies that were done in Europe and that then were duplicated here and used to help formulate these guidelines generally used Symbicort, which is budesonide combined with formoterol. They list this as a strong recommendation, high certainty evidence for ages greater than or equal to 12 years, moderate certainty of evidence for ages 4 to 11. This is the first time that the guidelines recommended intermittent use of an inhaled corticosteroid rather than daily use. And that's a big change. Up until now, ICS formoterol was used as strictly as a controller medication twice a day on an everyday basis. This SMART, S-M-A-R-T, which stands for Single Maintenance Reliever Therapy, uses this combination of inhaled corticosteroid and formoterol for both purposes, as a controller and as a rescue inhaler. The rationale for that is that formoterol specifically, as a long-acting beta agonist, is also fast-acting. It is almost as rapid of onset as albuterol. So they'll probably talk about this later in the discussion, but in Europe several years ago, they started to recognize and did studies that demonstrated that in the setting of asthma exacerbations, if they used a combination inhaler like Symbicort with budesonide formoterol, if they used that as a rescue inhaler instead of albuterol, they actually got better control of the asthma symptoms during exacerbations. And so that was reflected in the GINA guidelines last year. And currently in Europe, they're not recommending albuterol as a rescue inhaler. They recommend now the low dose budesonide combined with formoterol as their rescue inhaler. Again, there's a little discussion here on my slide. This is treatment that would be used in step 3 and 4. This combination is budesonide formoterol, which is Symbicort in the US, or mometasone formoterol, which is Dulera. This usage is currently off-label. So in spite of this being the recommendation, you may still have to deal with the realities of off-label use and whether insurance companies will reimburse for this modality of treatment. This slide is talking about in children 4 years and older and in adults with mild to moderate persistent asthma. If they remain adherent to their daily inhaled corticosteroid treatment, increasing the ICS dose at the time of symptoms doesn't seem to be effective. These studies were looked at a while ago. I don't know if many of you would recall that, but growing up in the asthma world, and especially in pediatrics and with inhaled corticosteroids and the understanding that they're so much safer than taking even short courses of systemic corticosteroids, we would frequently recommend our patients that were on daily controller therapy with an ICS that as soon as they started to develop an upper respiratory tract infection or symptoms suggestive of that, that you would double their inhaled corticosteroid. And then some guidance would say you should quadruple the ICS dose in that setting. And then there was a study that came out that actually looked at that and indicated that there really was not benefit by using that approach. And so I think the reason for this slide is because now the guidance is looking a little bit different. And the way that they looked at it was they realized that even though patients were prescribed daily inhaled corticosteroids, their adherence is usually not very good. And so that if a patient is either not on a daily ICS or they're supposed to be on daily ICS, but they're not really using it, if you then add this combination of inhaled corticosteroid with long-acting bronchodilator, you actually do see benefit in the acute setting. We can talk about this. Barriers for using ICS versus daily, probably one would be that patients are oftentimes ingrained into, we teach them you must use your inhaled corticosteroid every day in order for it to work. And even when you do use it every day, it takes time to work, etc. On the other hand, in barriers for using this single combination inhaler approach, one of the drawbacks certainly is going to be insurance coverage. If you have someone that's on a daily Symbicort, for example, but you tell them also then to increase their use of that when they're having an exacerbation, then they run out of their inhaler prior to their 30-day refill, and the pharmacy may not dispense the medication, the insurance may not cover paying for that additional. Just want to back up 1 second. So some of the ways to overcome the barriers: educating clinicians, educating patients, understanding that inhaled corticosteroids are not FDA approved for quick relief. The prescription will need to be off-label, and again, insurance companies may not cover it. Okay, long-acting muscarinic antagonists. The recommendations for LAMA in individuals greater than 12, if their asthma is not controlled with inhaled corticosteroid alone, first step is typically add a long-acting beta agonist rather than a LAMA. That's the guidelines that we've always followed. Then the recommendation would be to add a long-acting muscarinic antagonist if the LABA cannot be used. Perhaps they have side effects, they don't tolerate it, or they have a contraindication like glaucoma or urinary retention, or they simply can't get a LABA. Then adding a LAMA is an acceptable alternative. And then the other option would be to add the LAMA if the asthma is not controlled with combination ICS long-acting beta agonist already. In the previous guidelines in the EPR3, there was no recommendation for LAMA. The potential benefit of LAMA therapy has only come to light subsequent to 2007. So the next step in the story is allergen mitigation strategies. So basically, making recommendations like putting dust mite encasings on your pillows and mattress, using high efficiency particulate air cleaners, vacuum cleaners, not recommended if the patient has no allergies or no exposure to allergens. But for individuals with asthma who are exposed and allergic to specific indoor substances, using multiple strategies is recommended, because using only one allergen mitigation strategy is oftentimes not effective. So for dust mites, recommending impermeable mattress encasings are recommended only as a part of the approach. I believe that the only individual recommendation that seems to work is for pest management. Patients that are allergic and exposed to cockroaches, mice, or rats. That's the one situation where if you simply focus on eliminating those allergens, it seems to provide benefit. Having said that, we still recommend dust mite encasings for pillows and mattresses in many circumstances. Certainly in the setting of dust mite allergy, and in the setting of pet allergy when there are pets in the home, because clearly the pet allergen gets embedded in the fibers of the pillows and mattress. It gets carried into the bedroom on clothing, even if you try to exclude the pet from the bedroom. And so there still is benefit to doing that. The whole point of this discussion, though, is that dust mite covers in and of themselves may not be enough. And so they're one important step, but you have to then vacuum regularly with a HEPA vacuum, wash the bedding in hot water, and use other strategies like that in addition to just simply dust mite covers. And the reality is that when they talk about the pest management as a single intervention, it really is not a single intervention. There are several things involved with that. Eradication, again, vacuuming with HEPA filter, blocking areas of entry for the pests getting into the home, using pesticides and traps and cleaning, and all of this is part of that plan. So potential barriers, again, education is important, making the patients understand the importance of the exposure within the home. Try to keep from overwhelming patients with these strategies, maybe try to focus on the most effective first and add the others. Sometimes the cost is a barrier. Dust mite encasings are not generally expensive, but they can be. But other things like buying HEPA air filters are hugely expensive and sometimes of questionable benefit. HEPA vacuums cost money, and then the time and energy to do all of that. And then the next step is immunotherapy. So immunotherapy, commonly referred to as allergy shots, are recommended as an adjunct treatment to standard medications for individuals with mild to moderate allergic asthma who have demonstrated allergic sensitization and evidence of worsening asthma symptoms after exposure to the relevant antigens. The evidence reviewed did not support using sublingual immunotherapy specifically to treat allergic asthma. That is not a change from the previous guidance. The next step in the guidance overhaul is the use of fractional exhaled nitric oxide, or ENO, or fractional ENO. Nitric oxide is a gas produced by cells in the inflammatory cascade associated with allergic or eosinophilic asthma. The exhaled nitric oxide measurement or evaluation is a way of demonstrating evidence of allergic or eosinophilic inflammation in the lower airways. It's a relatively easy procedure. For most people, it's easier than spirometry. And when you have eosinophilic inflammation in the airways, you can then measure that as an elevation of the exhaled nitric oxide level. Remember that the purpose for using inhaled corticosteroids when we treat asthma is primarily to reduce this intra-airway eosinophilic or allergic inflammation. And so one of the values of the exhaled nitric oxide measurement is that it may help you to monitor over time how effectively or how well your patients are treating themselves with their inhaled corticosteroids, and may help to adjust the dosage, for example. It can also be used to help support the diagnosis of asthma when it's not clear. So spirometry doesn't always give us the answer. You know, sometimes we'll see a baseline airways obstruction and does not get better with albuterol, or we'll see what appears to be normal airways, and then we may give an albuterol inhaler and we see a big response, even though it didn't appear to be obstructed in the first place. So adding exhaled nitric oxide gives us another tool, another way of helping us to understand, is this really asthma or not? It can also then be used as a way of managing the asthma moving forward, or at least another tool to help us to understand adherence to medications or the effect of medications as we move forward treating our patients. Can generally be used above 5 years of age. It is not a diagnostic tool by itself. It should never be used to make the diagnosis, only that to be used to make the diagnosis of asthma. When the EPR3 was published back in 2007, exhaled nitric oxide was so new that there was really no recommendation put forward in the EPR3. And again, it should not be used by itself to diagnose asthma or even to predict if a future exacerbation or severity. And in younger than 4 years, because some younger children can do this study, it should not be used as a measurement to predict that patients may or may not develop it. Bronchial thermoplasty, again, really doesn't apply to most pediatrics. Individuals 18 years and older. So what they're saying is even for individuals 18 years and older with uncontrolled asthma, they should not undergo bronchial thermoplasty because the benefits are small, the risks are moderate, and long-term outcomes are uncertain. It's really designed for people with severe asthma that have not done well with traditional asthma therapies. Came on the market in 2010, and it was not FDA approved at the time of EPR3. Therefore, there were no recommendations in the 2007 guidelines. But again, more so in the above 8, well, certainly in the above 18 population, but this is generally a procedure that's used in adults rather than in children. And really only those patients that are severe asthma, simply not controlled with traditional medications. The other big thing that's come along since bronchial thermoplasty, of course, is the increase in the number of biologic agents that we use for treating asthma. And in many cases, those appear to be safer and more effective way of controlling otherwise refractory asthma. So that's all I have on my slideshow. I'll be happy to take questions. And also just recommend that you feel free to take a look at the guidelines themselves. And I have a couple of other simple references that might be useful. I'll see if I can figure out how to share those with you here at the end.
Stephen,
So, go ahead.
there's a couple of questions in the chat box that I just wanted to make sure you got to address. Dr. Chandler asked about, I don't know if you can see those, for a little bit more information about the bronchial thermoplasty. And also Dr. Keel asked about recommendations with regard to the use of Singulair.
So the Singulair guidelines haven't changed since the 2007 EPR. For those of you that remember the history of Singulair and asthma guidelines, Singulair came to market just before the original set of guidelines in 1997. And at that time, the 1997 guidelines indicated that for mild persistent asthma, that Singulair or Montelukast would be an appropriate controller therapy versus low-dose inhaled corticosteroid. In other words, even for children with mild persistent asthma, you could use Singulair or low-dose inhaled corticosteroids. That was the recommendation. But I would say shortly after those recommendations were implemented, it became apparent pretty quickly that Singulair did not control persistent asthma nearly as effectively as inhaled corticosteroids do. And those guidelines weren't updated for another 10 years. So from 1997 to 2007, that was the official guideline. In 2007, that was one of the major changes, was immediately said Montelukast should not be used as a controller, as a daily controller, unless it's an add-on therapy to at least low-dose inhaled corticosteroid. So Montelukast Singulair is still in that category. It's an add-on agent, but for control, either a daily inhaled corticosteroid or using the ICS SMART therapy approach with the ICS LABA should be in place along with using Montelukast. I hope that answers your question.
Dr. Marks, can I
Yes.
just add? I think one of the things too, Dr. Keel may be referring to is with the black box warning. But realize the black box warning just came out in March of 2020, and these guidelines had already been written and submitted before that. So there is no comment about the black box warning on Montelukast in the guidelines specifically. I don't know, Dr. Marks, if you want to share what you tell patients, or I can, but they are not remarked on in these guidelines. The black box warning is not addressed.
I'd be open to hear what you say, Melinda, and I kind of have a bias of my own as well, but
yeah, you know, what I generally tell people, especially in patients that have already been on it, is that the drug has not changed. It's been out for 2 decades and it has not changed. There's been some, concern or consideration for neuropsychiatric side effects. So those of you who are not aware, Montelukast, which is singular, since March of 2020 has a black box warning on it about potential neuropsychiatric side effects. So I just tell the parents about it so they hear it from us and don't hear about it on Facebook or from friends. I ask them, is there any concern about neuropsychiatric issues, which has been really challenging to ask people during a COVID year. But, and then if there is any history, especially if the patient is being treated for major depression or anxiety, or if there's ever been a suicidal attempt or ideation, I stop it. Otherwise, a lot of times we add Montelukast as an additional agent to get allergies and asthma under control, and it's added along with antihistamine, nasal sprays, and other measures. So I just kind of question, do they really feel like the Montelukast has added something to treatment? Is it really helping, and is it really necessary? If it's helpful, necessary, and they don't have any concerns, we continue it. If they have concerns, we stop it. And if they're not sure if it's necessary or not, I say consider a trial off, maybe save it for add-on for exercise-induced asthma, save it for add-on if it's a bad pollen season, but just have that conversation, and the patients seem to appreciate it. But the drug itself hasn't changed, so I really just kind of screen for that.
Yeah, I agree with that. When the Montelukast or singular came to market in the mid to early 1990s, the behavioral concerns were already noticed on the package insert. And yet, over this 30 years or so that it's been in use, we would rarely, if ever, see patients that actually were complaining of neuropsychiatric effects. So the black box warning, I think, got somewhat politicized. I think there were some issues with particular patients that got elevated and kind of forced the FDA's hand to put on this black box warning. But I think realistically, it's very, very uncommon that you're going to see neuropsychiatric effects. And as long as you caution them ahead of time and let the patient or the patient's family know that here are the concerns and to watch for these. And if something happens, go ahead and stop it and contact us. I think you can probably still use Montelukast in the same fashion that you always have. And Dr. Chandler, not sure what in regards to bronchial thermoplasty you were interested in. Maybe you can send me a message offline, or I can try to figure out how to best assist you with that.
I just don't know what bronchial thermoplasty is.
Oh, what it is. Okay. So with bronchial thermoplasty, it's a procedure that's performed by pulmonologists using a bronchoscope. And what they actually do is they go in to the bronchioles as far in as they can, and they essentially cauterize or burn the smooth muscle on the outside of the airways. So with asthma, asthma being an airways problem, we worry about inflammation on the inside of the airways, and that's what corticosteroids and inhaled corticosteroids are used to treat, to control that inflammation. But on the outside of the airways is where the smooth muscle is located, and it's that smooth muscle that gets triggered in various circumstances by allergies or cold air or exercise or cold viruses, the usual things that cause bronchospasm. And that smooth muscle is where albuterol or bronchodilators work. They work quickly in the case of albuterol to relax that smooth muscle on the outside of the airway, opening the airway and allowing the patient's symptoms to improve rapidly. With bronchial thermoplasty, what they found is that patients that were having kind of a constant constriction of their airways from this smooth muscle contraction on the outside of the airway, if they just simply removed that stimulus by destroying the smooth muscle, it would allow their airways to stay open and they would have better control. And so it is a procedure that's really invasive, I would say. Involves going in with a bronchoscope and physically cauterizing or in some fashion destroying the smooth muscle on the outside of the airways so that the bronchoconstriction can no longer occur.
Thank you. So my other question is, what's the best treatment for exercise-induced asthma?
Haha. Oh boy. There are several strategies that can be employed. I think number one, far and away, is ensure whether this is purely exercise-induced asthma or not. In other words, make sure you're not overlooking mild persistent asthma that worsens in the setting of exercise, because that's really very common. So if it's persistent asthma, you want to treat it as persistent asthma. If it's purely exercise-induced, the recommendations typically include using a short-acting beta agonist like albuterol prior to exertional activities and during the activity and afterwards if necessary. And montelukast has also been shown to provide benefit in preventing exercise-induced symptoms. So those are the two generally accepted approaches for treating exercise-induced asthma.
Thanks.
The only comment I would add to that, Dr. Marks, if you don't mind, is making sure it's exercise-induced asthma, not vocal cord dysfunction. So especially if you're looking at a preteen, teenage, usually female athlete, put vocal cord dysfunction pretty high on your differential list, especially if no other concerns for asthma.
That's a great point.
Does anybody else have any other questions? Oh, here we go. Would you like to unmute yourself, Marianne?
Sure. I hadn't heard this before about using montelukast for exercise-induced asthma, and I wondered if you do that, is that an episodic thing where you just have them take it the day of the exercise, or how long before? Or is that something they would be on every day during their track season or something like that?
I'll defer to Melinda's guidance on that. My understanding would be just to use it on a daily basis. I don't know if Melinda has any different experience.
Yeah, I think, I'll go to it in that child or adult who exercises so regularly that, they're using the albuterol pre-exercise more than a couple times a week, because you have that disconnect of they're overusing their short-acting beta agonists, but yet they're doing it as preventative. So, if they're only needing it 1 or 2 days a week pre-exercise, then I'll just use albuterol pre-exercise. But if there's someone who between PE practice and actual competitions and stuff are using it most days, I'll do a trial of them on montelukast, although now I do screen for those mental health concerns first.
Thanks. Thank you both.
There's another question in the chat box.
I can ask
Okay.
Anna if you want, because first of all, thank you guys. This is Michelle Loffer. Thank you guys so much for this very helpful talk and review. A few years ago, I had a patient who was living in a trailer and there was lots of mold, and I'm recalling that there was some sort of state funding to help pay for the mold eradication because it was, landing the kid in the hospital constantly. I can't remember how we did that, but I'm wondering if you guys know, for these families who live where there's a lot of sort of infestations that are adding to the symptoms, if there are any state resources. I mean, these are usually renters, who have this situation without money to do this kind of stuff.
Michelle, I don't have any information about that. It's something that we could look into. I could try to get back with you on what I can learn.
Yeah, at one point there was something, and now of course that was like 10 years ago and I don't remember how we did it, but okay, if anybody knows anything, I'd be curious.
Yeah, I don't know of specific funding resources. I know, and I'm sure Dr. Marks has done the same in Hawaii, And here, you know, I've written letters for people in base housing. I've written letters for people in state supported housing, you know, about their housing needs. Like, would they be better without carpet? Do they need to ensure, you know, no mold? Do they need to be have extermination if there's cockroaches? But I don't know specifically, independent of going through their landlords or whoever controls that housing, to seek funding separate. So usually we just start with writing a letter to whoever's in charge of their housing about their allergy and the recommendations.
Anybody have any other questions for Dr. Marks? Did I miss anything in the chat box? I don't think we. Dr. Chandler just put in a link.
I don't know that any answer to the mold issue, but I think environmental sanitarians at the Muni, you know, it discusses how to file a complaint about mold, and sometimes those people may be able to put pressure on a landlord to try to clear up to remedy the situation.
Well, thank you for putting in that link. Any last questions? Otherwise, I think we have a few minutes to give back to your day. We certainly wish we could be in person for our grand rounds, but until our hospital conference rooms will allow more than just a handful of us, maybe in the fall, we can look forward to some in-person sessions. But thank you again, Dr. Marks, for your time today and updating us on these asthma guidelines from the NHLBI. And we will have this recording up in the next few days on our chapter website. Dr. Marks, would you be willing to share your slides as well?
Yes, I can make these available for sure.
We appreciate that. So thanks, everybody, and enjoy the rest of your week.
Thank you so much.